Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast. Today, I'm really excited about this one. We're going to be talking about something that I think we don't talk enough about, frankly, and that's adherence, and not just adherence, but the therapeutic alliance in the severely mentally ill population, or SMI. And I can think of very few people who are really as qualified to talk about this as my good friend, Dr. Peter Wyden. So welcome, Peter.
Oh, thank you, Andy. It's great being here. Thank you.
Sure. Well, I think we need to just dive right in here and start out with, we all hear the term SMI, severe mentally ill, and there's probably different definitions. How do you think we should be thinking about this for the purposes of our discussion?
Yeah, Andy, great question. I think we have a concept of people who have persistent symptoms, who struggle with their illness, and it's not just schizophrenia, which is schizophrenia is perhaps the poster child of severe mental illness because so many people do not fully recover. But it can also include people with bipolar disorder, especially psychotic, or people with chronicity, persistent depression that doesn't get better, OCD, diseases that we think are primarily driven by biological problems, primarily need pharmacologic interventions as part of the treatment, not the whole treatment. And a kind of chronicity or a kind of persistence so that they will need ongoing help or treatment in the long run, or at least we think that. They may not think that, but
right.
We think that.
Well, yeah, I think that's great to expand our thinking a little bit beyond. I think we all think of schizophrenia as the poster child for a serious mental illness, but this is important. I sometimes liken it to diabetes. We think about with type 1, especially diabetes, no one would question that insulin is the core or is the foundation of the therapy, but you wouldn't just give insulin to somebody and say, eat all the chocolate cake you want. Of course, we would do other things, right? And what's also interesting is that adherence is not good with any medical illness, but it is especially bad for our conditions, is it not?
Yes, but I'm going to be provocative, Andy, and say that the title of this is wrong.
Okay. It's
not about adherence. And I'm going to say why I'm saying this, before you throw me out of this podcast. But it's about outcome.
Okay.
It's about helping our patients lead better lives with fewer symptoms. And in as much as taking our prescribed meds is important for outcome, yes, that's important. But I think from a therapeutic point of view, one key message is always start with outcome and then move the conversation to adherence, both in terms of your heart, what you're thinking inside, and how you communicate to patients. And I would say another point of this is that we've just started this podcast with the benefits of medication, which are unquestionable. Yes, I'm a card-carrying psychopharmacologist, but I think, and you'll hear why, to help patients adhere, we also have to be honest and not oversell it and empathize with the limitations of medication and why it's so frustrating. Again, moving the conversation to outcome.
Well, this certainly is a provocative point of view, and I'll be honest, I would expect no less from you, Peter. I think that's what we're here to do is
to provoke,
to challenge, and then ultimately to educate our audience. So it sounds like what you're talking about is to not just focus on how many pills someone is taking. Are they taking pills as I prescribe? But you're talking about bringing them into the process, which I guess we would call therapeutic alliance.
Yeah, that's often a catchword. Therapeutic alliance is often used for chronic mentally ill. It's really an old-fashioned analytic term. But I think, and whichever term you want, it could be the doctor-patient relationship or the clinician-patient relationship. If it's with a team, you might call it therapeutic engagement. It's basically, how does the patient view you or the treatment team as on their side. Are they allied with you or not?
Mm-hmm.
And that sounds touchy-feely, Andy,
Yeah.
but it's not. And I came through this the hard way as a psychopharmacologist after my training. And after years of research, man, did I realize that if you don't put therapeutic alliance or whatever what you want to call it up front and center, everything else goes to hell.
Yeah, we don't talk enough about. I think we all give lip service to the treatment team, and these multidisciplinary and things like that. But I think you're talking about something much more important, which is putting the patient front and center. And it also brings up another term we hear a lot about, which is shared decision making. Tell us a little bit about what that means and how that gets brought into the therapeutic alliance.
Well, yes and no. And for those in this podcast who are psychopharmacologists or medically oriented, there tends to be a sort of recoil sometimes about, oh, this is too touchy-feely. These words don't really matter.
Mm-hmm.
And whatever word you want to do, they matter a lot. For those in the audience who are not prescribing, we may seem a little hard-assed with this, but shared decision is one way of bringing the patient into the conversation. Sounds good on paper, but it is hard to do in many different ways. So, it's one of these things. It's easy to say and hard to do. So, we can get right into it. Often the clinician is afraid if I share decision, okay, they're going to say, all right, I'm going to stop meds, or I'm not going to do what you want, or whatever. And that then sets up tension. And my point is often, not always, when we bring up adherence or ask patients about adherence or make interventions about adherence, there's an implied, you screwed up, patient, what's wrong with you? And I'm not saying that you say that, but It's in the tone or the attitude or the way it's brought up.
Yeah.
And guess what? If you bring it up that way, are you going to help your alliance? Is the patient going to like you more? I'm being provocative, but the answer is no. So I think that the way to go about this is to have an attitude or an approach to the patient where you are doing your work, a large part of which is adherence, but in a way that's fun or interesting to the patient, not punitive.
Right.
Easier said than done.
But of course, bringing the patient into this means understanding what are their goals, what would they like, and what's a good outcome for that individual patient, because of course we have to individualize. Not everybody, is going to finish college, for instance, or get married, but whatever their goals are.
Yeah. I think what you're saying, Andy, is a kind of version of motivational interviewing.
Okay.
That you don't start with the symptoms. Most notoriously is you don't start with the PANSS score or,
Right.
You're a 4 on delusions,
Yeah.
right? You start with what's important to the patient in life.
Right.
And then anchor, I want to get married. I want to finish school, and anchor your treatment recommendations around that later. But I would argue that yes, that's essential. But if the patient then said, "Oh, now I get it. I'm taking everything," or there are no glitches or problems, we wouldn't be having this conversation. It's when there are differences between what the patient's goals are and their behavior, or if they're not following a regimen that we know is going to be in their best interest to make their goals, but they're not for whatever reason, then what? What do we do?
Right. Well, it seems to me...
And I'll tell you what we should do, but at least what I think we should do, but, by the way, to those listening, everything I say is not going to work a lot of the time. Okay.
Well, hopefully some of what you say will work.
But I will, after a lifetime of research, I hope to give you a few helpful pearls in this.
Right. Well, you know what this reminds me of when you're talking about bringing the patient into this and considering them? When I was a medical intern, I did an internal medicine residency. They handed us all this thin little pamphlet written in the 1920s by someone named Francis Weld Peabody. And it was very simple. It said the secret of caring for a patient is to care about the patient. It seems to me that can be communicated to the patient.
Absolutely.
So how do we do this?
Absolutely. Well, you don't want to blow it over getting pissed. So let me give you a few examples here. You work very hard to get a treatment plan that is in the patient's best interest, right? And the patient buys in. And then the next time you see that patient, they stopped whatever. The natural reaction is to be annoyed.
Yeah.
They've messed up my treatment plan.
Yeah, and they didn't listen to me.
And they didn't listen to me, And so there's a natural tendency to be annoyed. And that can be shown in your voice. Why didn't you do that? And I think that is a mistake.
Yeah.
Because if you tip that off, number one, you're telling the patient you disapprove of them. And number two is you're making it less likely they'll ever be honest with you again. And number three is you lose the opportunity to learn what happened.
Right.
So what I would say is control your emotions and try to be dispassionate about behavior that is not in the patient's best interest when you learn.
Yeah.
And I start that in the beginning. When I first meet a patient and I'm doing an assessment, right? I will talk about adherence and also other undesirable behavior, like undesirable to us, like getting high. And the chances are good that individuals had many other relationships with other providers. So how do they know if they tell me the truth, how I'm going to respond? Will I be punitive?
Right.
Or will I be helpful?
Right.
So somewhere in the initial assessment, I will review, hey, you and I here's my recommendation. Very commonly people don't follow recommendations. And while I think you should, I would rather hear if you don't than not hear.
Yeah.
Okay. Yeah. So, and then very important, I say, I promise I may not agree with you, but I promise I won't get mad at you. I promise it will be okay, assuming you can, right? Now, there's another corollary to that is when you ask a patient to disclose to you things that are, might quote unquote get them into trouble, right? I think it's important to say why they should tell you. And that what I emphasize not only is don't emphasize, oh, this is bad for you, right? I emphasize your treatment plan. It's a lot safer if you tell me what you're actually taking. If I get the information, I can help you more. I know what's working or what isn't and so on. So one example of that would be is if the patient's on a truckload of meds and you don't know that they're taking 1/10 of that and then they get hospitalized and then they continue the med list, you're going to have a comatose patient or someone at risk of NMS or delirium because you don't know. So I emphasize that, but most important, I emphasize how I will respond in advance. And as much as I can, it's not punitive. And the reason it's not punitive is I'd rather have information, even if I don't agree with it, than not have information because it's safer and it's better. Now, will this work all the time? Absolutely not. And the other thing is that, some patients will not know that they're not adherent because they have schizophrenia and they might accidentally stop. Other patients will intentionally stop. And one more point I'd ask the audience here, who are working with these patients, if it gets frustrating, ask yourself or your family if you've ever lied about your adherence to your doctor. Okay.
Mm-hmm.
And if the answer is yes, you have, I have, then ask yourself, why did you not fess up in truth? I've done this in audiences. The chances are good that usually we don't tell the truth to our clinicians because we don't want to be scolded and we don't want to be viewed as a bad patient.
Right.
And we don't want the patient, the doctor or the clinician to not care, stop caring or trying in our case.
Right. Right.
So I think if you think about it that way, you will know the reasons why someone may be hesitant to level with you.
Well, I think what you're saying is it's very important to take a non-judgmental approach. And it sounds like you're also saying it's important to be curious. And I've always said to be a good clinician is to be curious. You part of how you show that you care about somebody is you ask questions and you listen to what they have to say and you value what they're saying to you. And I think we've all experienced this in our own lives too. If you're in a conversation with somebody and they're going, yeah, and they're looking at their phone, you're not going to tell them as much as someone who genuinely asks a question and listens to you. And I think you've said it best. We're only as good as the data we elicit. And so the more data you can get, the better. And if you're curious, they're going to tell you more.
Right.
Yeah.
Right.
Yeah. So
very nicely said, Andy.
Well, like you, I've thought about this a lot, like you.
Yeah. Let me give the audience an example and give you sort of a case that I would, sort of in my research, and where clinicians, I think, get it wrong.
Okay.
Often get it wrong. Not you, not anyone listening here, of course, but maybe your colleagues.
Yeah.
Let's say you work really hard. Patient has schizophrenia, has positive symptoms of their illness, delusions, hallucinations, and they suffer from this.
Right.
And you come up with a wonderful treatment plan and it works. And then they come in and they stop their meds and say, okay, why? Tell me. So we're going to do the Cutler approach. You're curious.
Yeah.
Hey, not like you fool, but hey, okay. Well, so what I would usually do is thank them for telling me because it might be hard for them to tell me.
Yeah, that's good.
Right. And then I'm going to do the curiosity. So tell me what, at last I thought, it was helping and, I'm a little confused. You told me it was helping last time. Now what's happened? Tell me what's happened.
Well,
they say, oh, it's a side effect.
Yeah.
It was a terrible side effect.
Wow.
And then you say, oh, what was the side effect? And they say, Doc, it was voices. Those voices came back and that was a side effect.
Yeah. Yeah. And they told me not to take the medicine. Yeah.
Well, no, I'm going to make it a little harder for everyone.
All right. Yeah. They're just
the voices are a side effect of the medication.
Got it. So they misperceived it. Yeah.
Now I'm going to give you two scenarios. What most people will do is there'll be an automatic reaction. No. You got it wrong.
Right. I see. Yeah. No, that's not a side effect.
These meds are for voices.
Right.
Can't be a side. You're going to kind of react to kind of correct what the patient says.
Right.
I think you're better off saying, boy, that's interesting because I'm kind of confused. Here I am prescribing these meds because I think they help voices, and you're telling me it's a side effect. Tell me how that's a side effect. I don't understand.
Right.
And you got to do it dispassionately. If you
of course
are pissed and you pretend that you're not, it won't work.
Right.
And then the patient, will then tell you, well, you told me it works for my voices, and the voices came back. So I couldn't figure out what that was from. So it is a side effect. So if you learn that is golden information.
Sure is. Now, I love how you did that too, Peter, because I was taught to try to avoid the why question. If they knew why, then they wouldn't need you, So what you just did was beautiful. Wait, I'm a little confused. How do you explain this? I had a professor who said, how do you account for that? Or how do you explain that? Ways to avoid the why question. But I love how you just modeled it.
Yeah.
And it's just.
I agree. By the way, I agree. You don't want to start with why.
That puts people on the defensive too when you do
defensive, and they always make. But if you then say, I'd like to understand.
Yes,
and I'll tell you another trick
yes.
I've learned.
Help me understand is a great phrase. Yeah. Yeah.
If you're in the office, and this is also true in marriages or life,
Mm-hmm.
if someone says something that seems quote unquote crazy or patently false,
Yeah.
like you can't figure out where the side effect is causing voices or whatever it is, like, wow, I don't get this. Make a mental note.
Mm-hmm. Mm-hmm.
Assume that the patient is absolutely correct, that they are right.
Okay.
And then make a mental game of it. They're right. Then the game is, how are they right?
Mm-hmm.
How is it that the patient's right? And not say that you're going to agree with the patient,
Right.
but that will help guide your interview,
Right.
to make it into that. At least it helps me. Now, another thing you've noticed here is try not to correct too early. And what I mean by that is we have been trained, if someone says, I'm hearing voices because it's a side effect of the meds, we're trained to automatically say, no, that's what, you can always correct later,
Mm-hmm.
right? Once you get the information.
Mm-hmm.
But if you correct too early,
Mm-hmm.
you can't go back
Right.
and have it's much, much harder. So I call this, and this is very hard for me to do because I say you can hear this in this podcast. I tend to want to talk over you, Andy. Sorry. Because I have a genetic disease called a Y chromosome.
Yeah.
But I suggest to clinicians that if you want to correct someone, imagine duct tape and put it over your mouth for a while. Okay. Cause you can always make that correction later,
Nice.
but you may lose the opportunity to better understand.
Yeah. Yeah. That really makes a lot of sense. And, I also was taught that your perception is your reality. So, you don't want to necessarily try to talk somebody out of something. And then if you do that, of course, you're sort of training them, as you said, to not tell you things because they don't want to be corrected. They don't want to be criticized. So I think this is really helpful. And another question that comes to mind is, how common is this really that we see, what you prescribe is not taken in the way that you prescribe it with our patients? Because I think, look, I'm guilty of this too. I think that I'm a terrific doctor. I think I have great relationships with my patients. So of course they're going to take the medicine and be part of my brilliant treatment.
Yeah. Oh, yeah. Well, you are. You're wonderful, and no one's ever been non-adherent for you.
Right. But
or me.
The fact is
but the great different. Unwashed clinicians.
Yeah, the facts are different.
Yeah. So I have a few thoughts on this, and this will be, so first of all, our language. I like to say we know what we prescribed.
Right.
We don't know what the patient took. So I use that word. I prescribed X, not the patient took X. Mm-hmm. And that just is sort of a reminder that they may not be the same thing.
Mm-hmm.
Number two is I think that there is this tendency, that we know the literature that clinicians miss their patients' non-adherence all the time.
Right.
But there is a tendency to mistake a good relationship. And this is actually the other side of the coin, where a good relationship with a patient can mess up adherence.
Okay.
I get along with my patient, so therefore my patient will level with me. Right? So it may be true that you get along with your patient, have a great alliance, but that actually may, unless you've done the proper groundwork, make it less likely that the patient will tell you, because they don't want to hurt your feelings.
Right. That's right.
They don't want you to get pissed.
They don't want to disappoint you.
So whenever I hear a clinician say, I have really good relation with my patients, therefore no one would ever not tell me the truth. I don't buy that.
No.
For the following reason is you can have a great relationship with your parents, but you're not going to tell them you're smoking cigarettes or having sex if you're a teenager, right? I mean, So that also gets to, don't get into a violation of trust. If my patient isn't leveling with me, it's a violation of trust. Come on. You can trust someone.
Sure.
And still not tell them every little dirty thing you're doing, like not taking the meds or getting high, or,
of course.
My wife, when my daughter turned 14, she said, our daughter is going to tell me when she's having sex. She tells me everything.
Yeah.
I said, yeah, right. And then a few months later, she asked for the IUD,
Yes.
Right. It's not a question of relation.
No, that's well said. Something else occurs to me too. When we're talking about serious mental illnesses, very often we're talking about illnesses that affect parts of our brain that have to do with self-observation, self-awareness, judgment, insight. And that can distort this too, can it?
Oh, yeah. Yeah. Oh, we could go on with that. So again, nothing I will say is foolproof, but some people don't realize they're sick.
Right.
And there's a popular word, anosognosia, unawareness of illness.
Yes.
Right. And that is true to some extent. And then those folks will probably not become members. I'm going to default to schizophrenia and antipsychotics, but this could be for anything.
Sure.
They're not going to be walking members of I Love Antipsychotic Club, right? So because they don't think they need it. Now, there are a few caveats to this, that there's a difference between, like, I just don't know I'm ill because I have something's wrong with my brain and I don't understand that.
Right.
And the world is against people with schizophrenia. That is a terrible illness. I just watch any movie or anyone talk about it. So I don't like the word schizophrenia. Right. So if you tell me these meds are for my schizophrenia, no, thank you. I'm going to walk from that. Right. So before we write off everyone as anosognosia, as some neurologic illness, it's not up to us as clinicians to force patients to accept the schizophrenia word.
Oh, no.
Most clinicians treating schizophrenia know that if the person says, is willing to accept meds and not. But it's important to tell families that because they'll say, see, Johnny, you're taking meds for your schizophrenia and now that works. So you got schizophrenia. Yeah. Well, if they say that next week, they stop their meds.
That's right.
So, now I kind of thought you would say something else though, Andy, and that is that not only do these patients have sometimes self-observing problems, but they're going to have problems with memory and motivation.
Well, that's a good point too.
And things like that. And that, maybe that has something to do with their not taking meds regularly.
Absolutely. Well, you can forget if you took it or not, the motivation to go to a pharmacy or whatever it is. I think those are all definitely parts of this too. And I think, like you said, you may acknowledge that there's a problem or even you have a specific illness, but you are not necessarily aware of the consequences of the illness or the fact that you need the medicine or even that it helps you. You may think I've got it under control or I should be able to control it. So there are other reasons.
Yeah. Yeah, there are many reasons.
The other thing...
In fact, there are so many reasons, Andy, that messes clinicians up who are starting in this.
Yeah.
Can I explain? That was kind of a hint that I should explain that.
Okay. Go ahead. Go right ahead.
So at least when I was doing more teaching on adherence, right? You go to a lecture on adherence, you read a chapter on adherence. The beginning of the chapter says, if you stop your meds, that's just, leads to bad outcomes. And then,
of course.
And then later on in the chapter of the lecture, it's like what causes non-adherence.
Yes.
And then you see what I call the laundry list, 97 reasons the patients stop their med.
Right.
And you go, oh my gosh, all my patients have half of these. Like, I'm overwhelmed. I can't deal with it.
Yeah.
So I have a suggestion, something that works for me on this. And maybe if you're overwhelmed, say, well, how can I understand the different reasons? why people stop their meds, and this isn't foolproof, but it can be helpful, is, especially in an illness like schizophrenia, divide up your thought balloon in, is this person struggling with adherence because they won't take the medication? They're making a decision that they want to stop medication.
Mm-hmm.
And my own mental notation for that kind of patient is will not.
Mm-hmm.
This person will not take the medication regularly.
All right.
It's a conscious decision. And then there is the patient who they're not against taking antipsychotic medication. Again, maybe they're not flag waving members of I like to take medicine, but they're okay with it. But they have an illness where it's very hard for them to get to the pharmacy. It's very hard for them. If their meds run out,
mm-hmm.
they won't, if you have negative symptoms, you won't call the doctor or the pharmacy to get your refill.
You don't plan ahead.
Or you're going to make medication errors or,
mm-hmm.
whatever. And I call that kind of patient cannot take the medicine. And what I say by cannot is not that they physically can't take the medicine,
right?
But that they have some aspect of their illness
mm-hmm.
that creates a greater barrier than it would to you and me. I sometimes use the analogy that, that would be like asking someone with, multiple sclerosis to go to a second story walk up for their meds. I mean, that if you have multiple sclerosis and you can walk, maybe that's okay,
mm-hmm.
even though you'll think what's that all about?
Mm-hmm.
But if you can't walk, you're not going to get meds. So you might want to, in this 97 variety laundry list,
mm-hmm.
try to define, if I'm dealing with someone who might not be taking meds regularly, which is everybody,
mm-hmm.
then is the primary obstacle
mm-hmm.
that they're making a decision
mm-hmm.
not to, versus are they, disorganized or just
mm-hmm.
not really able under their certain circumstances to take meds regularly. And of course the interventions are very different for that type. This doesn't work all, it's like, if I don't really think I'm sick, I might not be I might forget more, there's some overlap, but
sure.
But I think to me anyway, that's been very helpful in therapeutics.
That's extremely helpful, a way of kind of organizing these reasons that we're talking about. The other thing is, I don't think adherence is binary. It's not all or none. As a matter of fact, most patients probably are taking the medicine some of the time. And I always ask two questions. The first one is, are you taking the medicine? And they always say yes. And I don't think they're always lying, because my second one is, okay, are you taking it the way I prescribed it? Getting back to your point about prescribing it. And then you hear, well, I take it on Tuesdays or when I feel like I need it or if whatever. Right. And that's,
yeah.
Do you know what I mean? And that's dynamic and that's incomplete adherence. And I think that can be almost as bad as complete non-adherence, but there's different reasons for that as well.
It can be. A lot of it depends on the med and how much. So I'm going to answer this two ways. I'm laughing because I'm thinking of my case, lovely young woman
mm-hmm.
who I treated in Chicago,
mm-hmm.
who I had a good relationship with.
Mm-hmm.
Right. So I asked her to take the medication for me. I was taking advantage of my relationship with her because
mm-hmm.
she was reluctant to take the medicine.
Mm-hmm.
So will you take it for me? I'll see you in a month.
Mm-hmm.
I then saw her and asked her, so did you take the medicine? Yes, I did. And so she went home and took one pill that night to do it for me. And then she was free. Then she was done with doing it for me.
That's,
So, So absolutely. You want to kind of have the conversation. But some people won't remember or things like that but yes.
Well, this is a good point too.
Absolutely. Yes.
This is an excellent point because sometimes what we say is not completely heard. And I'll tell you a quick story. Years ago, I was doing a schizophrenia maintenance trial and we had this guy who did very well early on. And about 6 months in, he starts getting wonky, but not quite bad enough to rehospitalize. And he comes in for a 6-month visit and says, by the way, doctor, what would you like me to do with this bowl of pills I have at home? I said, bowl of pills? What are you talking about? Well, what he heard was that the medicine came in a blister pack and he was supposed to pop them out at one a day and that we would count them. meaning, of course, when he came back, we were going to do a pill count of the ones he had taken. Well, he popped them out, put them in a bowl, and was wondering, when are we going to count the pills? And he brought the bowl in. He had all the pills there. And, his pill counts had always been...
Oh, what a story.
Isn't that great? His pill counts were 100% because he popped one out every day. And we were looking at the empty cards of the pill. So
what a wonderful story.
Isn't that a great example of the disconnect?
And I think yes. And it shows when you have a population that is not responding fully to medication. Like he wasn't.
No, there was something going on.
He has some cognitive issues.
That's right.
He's a little concrete.
That's right.
What a surprise.
Well,
schizophrenia. What a surprise.
That's right.
You can't make up.
That's right.
Some of this stuff.
Well, the point is that he wanted to follow. He was trying to be adherent, if you will. And so what that led me to, Peter, I learned something very important. I now have a patient or the family member repeat back to me my instructions or even write them down. So that has been one tool I have found to be helpful.
Right. Good for you. I mean, absolutely.
Sometimes we learn from our mistakes or our less than optimal outcomes, I would like to say, if we're wise enough to learn from our mistakes. Moving on. No. It's called life experience. Yeah.
I mean,
I like that.
Well, I'll tell you another area where clinicians often get adherence wrong and why I would recommend outcome, not adherence. Okay. You admit a patient who'd done very well on some antipsychotic, psychosilazine. Okay.
Mm-hmm.
And they're relapsing. And, you get the info that they stopped their meds a week ago and, so that's non-adherence. Okay. So like all of the so you're going to call that, stop meds, non-adherence.
Mm-hmm.
And that is true a lot. There's no question about it. One of the biggest predictors of relapse is stopping your meds.
That's right.
Absolutely. But it's about efficacy. And there are many individuals where the meds don't work well enough.
Mm-hmm.
So let's now hit the rewind and you find out that the medication stopped working. Person was taking it, but had stress and started hearing voices telling him or her to stop the medication. And then that made a bad situation worse, right? So in those two scenarios, the first version looks like pure non-adherence. You might do an LAI or whatever. The second version is maybe it's an efficacy issue. Maybe this med that I thought was holding the patient wasn't good enough. Maybe I'd either need to raise the dose or change the med.
Right.
So one of the things that clinicians, I think, often could, again, don't start with adherence, start with outcome. Why is this person not getting the outcomes I expect?
Mm-hmm.
And yes, adherence is a big issue, but then think about, if there is an adherence problem, is that a primary problem? Or is the person not responding well enough and therefore, and then stopping their meds and then that's gasoline to the fire.
Well, this is an excellent point, and it reminds me of our good friend Jonathan Meyer, of course, wrote a tremendous handbook on antipsychotic plasma levels. And one way to sort this out, one way to sort it out is to get a plasma level. And if they're having the therapeutic plasma level, then you can certainly conclude it's inadequate efficacy. But I want to mention something else.
I think that would be suggestive evidence, but
it doesn't prove it, of course. Yeah.
No. But, the plasma level. In all due respect, we need to do more plasma levels. You should read his book.
Yeah, it's terrific.
But I also think there's no substitute for a good interview, except maybe eventually digital measures where we can get real-time data, which comes first.
Sure.
But yeah.
Well, another aspect of this is we're talking about being outcomes focused, which I have to tell you, Peter, this is an eye-opener for me, and I think it's really helpful framing of it. I'm reminded of a story. We have to make sure that our goal for the outcome aligns with the patient's. And I'm reminded of a patient of mine many years ago named Rudy. I still remember Rudy. Rudy said to me something.
Not the Rudy that we see on TV, I hope.
No, not the Notre Dame Rudy. But he said to me, he said, please don't get rid of my voices. They're my friends. Just make them nice. Now, of course, in my training,
Yes.
I was trained eradicate hallucinations. Hallucinations bad.
Blow them out of the water.
Right.
Yeah.
Right. So now if I do overdo this and get rid of them, of course, he's not happy and he's going to stop the medicine. But if I can adjust my goals to say, okay, let me see it from his point of view. He's lonely. The voices keep him company. They're his friends, whatever it is. But off medicine, of course, they became persecutory and they were not nice, as he said. So I think that's another thing too. Let's make sure that our goals are aligned with the patient. What does a good outcome look like
And Andy, I know you. You are a very good listener.
Well, thank you.
And you would not have known that unless you'd stopped to listen and ask.
Right.
Right.
Well,
what's good about that?
Well, the technique is tell me about the voices. Tell me more. And again, demonstrate your curiosity. And then you get to these things, not are you hearing voices or not? That's very binary.
Well, also, this called into, I don't know about you, I was trained don't talk to the patient about their voices because you're feeding the fire. You're encouraging them by showing interest in the delusion. And nothing could be further from the truth.
I agree with you. I think that's not true at all. And what's always amazing.
That was the old teaching.
That was. And what's amazing to me, Peter, is how each patient's delusions and hallucinations are very personal. They're all so different, aren't they? They may have themes. So I want to know the particulars.
Yeah. And I will also tell you another secret that I think is very important. Now, when I say this to the audience, I am not anti-medication. I want my patients to adhere, okay? But let me tell you, our medications suck. Yeah, and I'm going to explain why.
No, I get what you're saying.
Okay, you see where I'm going to go with this. Okay, we want the person to take medicine. I see a patient, I want them to take medicine. I think it will help their outcome. So what is the natural thing to do is to try to sell that, right? Like you'll relapse less. It'll help your voice, I'm going to focus on the good side of this, right? Now, and I think that's appropriate, but what happens if you oversell medication? What happens to you, dear listener, if you go into a store and or to buy a car and someone says that car is perfect and all our, and better in every way than our competitor? Are you going to move forward, more likely to move forward with that? No, I'm usually looking for the exit with that kind of. So if you extol how wonderful these meds are, the patient is going to say, I'm not normal. I'm still not myself.
Right.
And what is the patient going to say? This person's BSing me.
Right.
Then the person will say, I can't believe anything this person's going to say. I don't trust this person because they're selling me a bill of goods. And I think they're quite justified at times. The way I hear these meds being presented is
Right.
So remember this. I think the way to remember this is that clinicians tend to calibrate response based on their experience with what the person would be like without medication.
Right.
And there'll be usually an enormous difference favoring medicine. Okay. Patients calibrate based on what are they like compared to what they were like before the illness. So medications can be wonderful and suck at the same time.
Right.
And I think we need to focus more in building our alliance with the patient as to the disappointments and the frustrations with these medications. I used to kid, when the atypicals came out, and I know you and I are old enough that remarkably better tolerated than the old Haldol and stuff.
Yeah, absolutely.
And I get so excited to give someone the first episode an atypical.
Yeah.
But I soon learned that if the first episode said, Doc, I feel like crap on these meds, if you say, oh, you should be grateful because we used to use Haldol and it was a lot worse 10 years ago. Yeah. So you should be grateful.
That's right.
That doesn't
sell very
so well. You know, right. So, you know, I would be, always think, am I overselling? What's my credibility here?
Well, I think
that that's important.
Yeah, and you're bringing up a very important point, which is to acknowledge the limitations of the medicines. For example, you're right. I am old enough to remember the era when these drugs were coming out, and we had high hopes for their efficacy for negative symptoms and cognition, for example. And we realized they ain't so hot for that. So I think we have to acknowledge the limitations, as you're saying, and recognize they can help some things, but not others, and they're not perfect. So I like that. Again, that's being curious.
And there's another, now you're getting me going. There's another trick. Okay. I don't mean trick like tricking the patient.
Right.
But I'm going to ask the audience to think about this. If you hear about safety versus tolerability, right?
Yes.
Safety is, does the medicine cause heart disease or,
right.
Right. And tolerability is, does it bother the patient? Right. Very often, tolerability side effects like sexual dysfunction or whatever are presented to clinicians as you should do something about this because it leads to non-adherence. Mm-hmm. Right? Mm-hmm. Now, that's all true, right? That if you have sexual dysfunction, it will lead to non-adherence. You need to interview but I would argue that if you wait on these side effects until the person stops their medicine, and only then do you get off your tush to do something about that side effect.
Right.
You are training that patient.
That's right.
To stop their medicine, to communicate with you.
Right. That's right.
So again, this is the deal with the misery or unhappiness of side effects and take them seriously. Even if you don't think they're that serious, if only for the reason that you want the patient to feel you have the credibility that you're taking that seriously. Don't wait until the person has tossed the medication.
Absolutely. Well, it
doesn't mean you have to, you might come and say, look, I can't do anything about this. It doesn't mean you have to, do everything immediately, but it means you take that seriously and don't write that patient off.
Right. Well, I always say people don't like surprises, so I think it's very important to, it's part of informed consent. Let them know what are the common side effects and the fact that there might be something we can do about it. What can we do about it? Not just short of stopping the medication. Right. The other thing, Peter, I think it's important, along with the line of being curious, is to recognize some people are more bothered by some side effects than others. Some people, for instance, are extremely sensitive to nausea in my experience.
Absolutely.
So I ask them sometimes, what would be a side effect that would really be troublesome for you? And I can often choose a medicine that has less risk of whatever that side effect is. Yeah.
Absolutely. That's a really good point. And, I'm sort of, in this podcast, I've asked the audience, I'm kind of emphasizing the kind of non-intuitive kind of stuff that isn't so obvious. But yes, the obvious stuff is, minimize the side effects that are most distressing to the patient first. And, don't take this podcast as, I don't do the basics. The basics are maximize efficacy, minimize side effects whenever you can, match the regimen to what the patient can take, and those sorts of things. This kind of stuff is a little more subtle, let's say.
Right.
And kind of more linked to the alliance.
Well, what would you say are some barriers to developing the alliance? We've kind of talked about a few, and then I'm going to ask you, what are some effective strategies to increase the alliance and improve adherence? So maybe barriers, and then what are some good strategies here? We want to leave our audience hopeful with some tools, some techniques.
Oh, yeah. Yeah. I think, and I've been trying to do that. I think one thing is in the initial intake, when you remember that the relationship is new, and that the patient will come in with assuming you will be like all the others, good, bad, or ugly. Right. So number one is don't take it personally if they're a little skeptical about what you say.
Yeah.
Because maybe they've come by that honestly. They've heard how wonderful meds are, and then, so understand that and bring that up, and don't say, oh, now you can trust me, but all the others you can't trust. You can trust me.
Right.
So let it develop over time. And again, in the intake, discuss how you're communicating, that it's safe. If it is safe, if they tell you they're stopping your meds and you have to hospitalize the person because of a court order, it's not going to be safe for them to tell you, but most of the time it'll be safe.
Okay.
Another trick, quote unquote trick, is that opinion matters. So it's not just the patient's opinion of you, but the spouse or the case manager. And you were about to say something.
No, I was just going to say maybe we can use the term tips or techniques rather than tricks. That's all. Nothing.
Yeah, sorry,
non-judgmental.
You're right.
Yeah, that's okay.
Yeah, that is the wrong. It is not. That's a much better word.
Or tricks of the trade, if you will. That's a good one.
Yes. Yeah.
No, but please continue.
For the listeners who've made it this far, I will change everything.
No, that's fine.
To that. You're absolutely right. Fine. Thank you.
Yeah. You were talking about maybe some techniques, some tips here for us.
Yes.
Yeah, for to work on strengthening that alliance. And I love what you said about you're starting a relationship. So it's wet paint, it's wet concrete. It hasn't formed yet.
Right.
And hopefully they'll give you a chance to demonstrate your caring and all of these things.
Yeah.
Your competence.
So another technique or another thing to keep in mind is that while it may be a little harder to develop an alliance with someone with a serious mental illness, you can be fooled that you're not as important in the person's life as you are. So first of all, for people who have very few relationships with others, if they see you for half an hour once a month, that may not be a big deal in your life, but it might be a major relationship connection in their life. So that's number one. Number two, remember that negative symptoms or those sorts of impairments make it harder for you to appreciate that the person may be connected to you. They may not have the hardwiring.
I see.
So there's a natural assumption that the person seems completely disconnected to me, therefore they are. Well, maybe that's true, but it's at least likely that the person is more connected than you think. So don't underestimate your relationship based on some of those factors. And it's okay to be nice. It's okay to talk about baseball. It's,
absolutely. Whatever they're interested
in. Things like that. Yeah.
The other thing I want to bring up, Peter, and get your opinion on is we talked a little bit about this earlier. I find it's not helpful to get into an adversarial position on you need to take the medicine to deal with the voices, or you need to take the medicine because you have schizophrenia. And often family will say to me, can you just convince him that he has schizophrenia? And he says, no, I can't. And what I sometimes say is I try to find what's distressing to the patient. And it may be anxiety, for instance. It may be insomnia. Now, I'm not going to lie to a patient, but I might say this medicine will help your anxiety or might help you sleep. And that's true. And I'm not necessarily fighting with them over, and it will get rid of your mistaken false beliefs that you believe to be true or the voices that seem real to you. Does that make sense?
Right.
Is that okay to do?
It makes a lot of sense. And I think the other thing to mention is if you do have to use the schizophrenia or whatever word they don't like, say, look, I have to make a chart diagnosis. That's what they say. I'm not that invested in it, but I need to do it for the record keeping as opposed to, I'm going to prove that you have this. I think that's to really make it as gentle as, but stay with a symptom and do the best you can with it. Absolutely.
Yeah. I mean, again, it comes back to putting the patient forward and what are the issues that bother them? What are the most issues that maybe will keep them coming back to see you and that they would consider a good outcome, not necessarily what we consider.
And it's been implied, but if they stop their medicine, stay with them. And then if you're not able to, use the agree to disagree approach, right? Okay. I can't agree with your decision. I do think it's too risky. So as your physician, but I understand why you're doing that.
Right.
So, but can we talk about safety? If you're going to do this, I'm very grateful that you have told me. Right. And can we do it in a way that will make it safer? And the way to make it safer is to do it, then you talk about a slower down titration. Right. And you then, it's classic harm reduction, go into harm reduction.
Yeah, mode. I like that. Well, certainly. And you really want to protect the alliance as much as you can. But what I often do, you mentioned this too, right up front, I will often acknowledge the obvious. I will say, it's hard to take medicine all the time. And it's very possible you'll stop your medicine. And so I kind of destigmatize it. And I say, if that happens, that's fine. Just please tell me. Let's talk about it. And maybe I can help you with that. So again, it's anticipating what's very likely to happen.
Absolutely.
I mean, if we're honest with ourselves, Peter, you and I take medicines. Can I honestly say I've taken every pill exactly as my physician prescribed? Of course not. And theoretically, we don't have schizophrenia, so. All right. Peter, with the remaining time we have, I do want to touch on something that is really important. And for old dogs like us, I think we can maybe learn some new tricks. What would the role of digital tools be? We know that technology is going to revolutionize medicine. We just don't know exactly how yet. But where do you see a role for digital tools in helping us with this?
It's a great way. So, we don't know, but it's going to get better and more important. So I'll just say a few words. In terms of being an adherence intervention, helping the person adhere, I think the low-hanging fruit for digital interventions is the patient who I would characterize as cannot, like, the person whose cognitive symptoms or negative symptoms is messing up their taking medication regularly. I think that can be very, very helpful. And we all get reminders now, and I find those very, very helpful. So the only downside of these is that many SMI don't have the same cell phone for a month or two, that their lives are a bit more chaotic. So it may be harder to do that regularly. But I think for the people who have trouble with organization and so on, I think it's a godsend. I think the jury is still out about for the will nots, if I'm reluctant to take it, there are cognitive behavioral interventions about adherence. I don't think they can take over the human connection, but they might be able to supplement that.
Right.
The two-edged sword is if the patient gets frustrated over the app not working or so on, you don't want to, make that, you don't want to lose the patient based on their frustration over the app.
Right. Definitely. I've been surprised though, Peter, how many of our patients do have cell phones and are quite facile with technology. So we shouldn't assume that because they have an illness.
Absolutely.
We shouldn't assume they can't do this. These digital interventions, they come in a couple different flavors, of course. There are some that are meant to be therapeutic in treatment. There is one in development right now for the negative symptoms of schizophrenia, for instance, you may be aware of.
Absolutely.
And then there are some meant to enhance adherence, as you talked about. There are some that are gamified, that are fun, and that do things like micro-incentivation. If you do something like take your medicine, a little bell goes off or you get a little star or something like that, that makes you, it's reward-based.
Can I get that for me?
Oh, wouldn't that be great?
This is great. I mean, I think all of these are great. I think the challenge from a research point of view is all of these will work, or not all of them, I'm being somewhat dramatic, but many of these, I believe, will work for a certain subpopulation of people having trouble taking their medication.
Of course.
If you do a clinical trial and you take all comers, It may be hard to find out how helpful these are. But absolutely, I completely agree. Very exciting about the negative symptom intervention. Very exciting about gamification.
Right. Now, the other way digital tools can be helpful is in obtaining digital data, real-time data. There's something called EMA, Ecological Momentary Assessment. These cell phones.
EMA, right.
These cell phones we carry around with us carry a wealth of information. Of course, there's GPS. You can see how active I am. There's things like prosody of speech can be recognized. You can pop out little questionnaires. How are you doing right now in real time? They can also monitor how often are you calling or texting or searching on the internet or using social media. So this is all real-time data that can help you decide if your treatment is effective or not. I think that's a new frontier.
Yes, a new frontier, and I think it will really revolutionize, especially I think what you're saying here is, if you recall the case where the symptoms come first and then the non-adherence comes second, if you can find early interventions that are more sensitive, detecting early signs of relapse, that is huge. So one example, a colleague when I was at University of Illinois was looking at how quickly does the person text as a sign of early signs of mania.
Interesting.
How do they do their handwriting or what are they looking at? And that, that will come, and I think that will be enormously helpful.
Well, sure. It provides objective evidence and, again, real-time evidence, and perhaps you can intervene earlier. Well, Peter, I feel like there's still many other things that we could discuss, and we need to do this again because I really enjoy speaking with you, but unfortunately we're out of time.
Well, thank you for the opportunity. It sounds to me like, Andy, you should do one on digital only because this is the tip of the iceberg.
That's a great idea.
And it is a different world.
It is.
And I'll interview you.
All right. Fair enough. We'll turn the tables. Well, listen, I want to thank everybody for listening to us. Hope this has been helpful to you. Thank you so much, Peter, for your time and your expertise. You are a wealth of knowledge.
Thank you. This was a lot of fun. Thank you.
And for more information on our other educational offerings, including other podcasts, including my psychopharmacology series with the one and only Dr. Steven Stahl, information about our live meetings, our tools to help you in your practice, please go to our website, which is www.neiglobal.com. Thanks very much. Talk to you soon.
Thank you for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.